Hi, and welcome to Covell Conversations. My name is Krista Covell Pearson. I'm an occupational therapist and the owner of a mobile outpatient private practice in Colorado. If you're new here to this station or to me or to our YouTube channel, guess what? So am I. This is a new venture for me, and I'm sure I'll make tweaks as I go, and it'll just get better and better, but you have to start somewhere, and this is where I'm starting. So at Covell Care, we have a focus every month, and that's my private practice is Covell Care. We have a focus every month where we look for resources, new research, ways to educate the community on different topics. And in this month of December 2025, we have landed on mental health, which of course is a huge umbrella that encapsulates so many different things that all of us deal with. And mental health can mean something different to you than it means to me. My very first job as an occupational therapist was in inpatient psychiatric care, which was very eye-opening to me. And then I also, being a mobile practitioner and going in and out of people's homes, and we're talking people of all different ages, all different health statuses, all different families, backgrounds, all the things, I have had to really figure out how to integrate people's mental health just as well as I integrate their physical health into the interventions that I'm providing. Because if I don't, I'm missing a huge piece of who a person is. And as a holistic practitioner, which an occupational therapist very much is, we're looking at the environment, the person, what's meaningful to them, who's influencing them in their lives. I have to be able to weigh out people's mental health. And that can mean maybe somebody's dealing with situational depression. Maybe a spouse has just passed away. Or maybe we're dealing with something more challenging, such as depression, anxiety, bipolar, dissociative disorder. And we're really having to peel away the layers of the onion to figure out what is influencing this person, what is holding this person back, and how can I help them become more functional. So prior to being an OT, I went to social work school, and I learned then and there how important it is for all of us as healthcare providers that we take care of our own mental health and our own challenges and our own issues and our own downfalls when it comes to our mental health and coping strategies, which is ongoing. You don't just figure it out and then you have it all figured out. It's a lifelong learning process. And then we all go through trauma in life that also influences us. But we have to take responsibility for our mental health and our capacity in order to best serve the patients that we are arriving there for. Because if we don't, then we are at risk of influencing them in a way maybe we don't want to. So here's an example. I worked with a physical therapist for a long time who went through a pretty rough situation, and she went through a pretty difficult divorce. And when we would contact her patients for follow-up, how did it go? How's your therapy doing? How's this? How's that? We would consistently get good feedback on her clinical skills, but we also had feedback often from a place of love that we're very concerned about her. She seems to be very stressed. She told me all about XYZ. And it got to the point where we actually had to address it from a management point of view because there were roadblocks because of that getting in the way of being able to provide good care and to stay patient-centered. It's great because there's a fine line to be like, oh, you're going through X and I've been through X. I can relate. Sometimes we can't relate, and sometimes we don't want to say that we can relate. But that's where the dance in mental health is really important to understand on what's appropriate for what patient. And, as an occupational therapist, OT is based in mental health. And then our profession the pendulum really swung the other way. And we really were kind of put into that very mainstream medical model. And now I think our healthcare community is trying to go back to also encapsulate mental health into what we do as providers. But let's be honest, we have a long way to go. We don't have a lot of funding. We don't have a lot of providers. And the things that are in place oftentimes are not enough or are not quite the right thing. So I wanted to talk about, on this Covell conversation, about the role of occupational therapy in the community with people struggling with mental health. If you have ever seen a psychiatrist, a counselor, a therapist, a social worker, And nobody has ever encouraged you to talk to an occupational therapist that has experiences with people dealing with different phases of mental health concerns. I'm sorry for that, because I wish that everybody could get that level of support. When I was working in inpatient psychiatric care, we would send patients home, and then there's a huge drop off as far as who's going to be successful, because people would go back to their same routines, same habits, same relationships, same coping skills, same challenges, same jobs, same family, same spouse, da 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 da. I can go on. And then things just fall back to the way they were. And if you're dealing with chemical imbalances or challenges with different substances, addiction, anything like that, then those triggers and those connections and those patterns are really tough to navigate. Not that they can't happen, but they're hard. And with support, it's better. So I see the majority of my patients in person. And like I said, I can see them all different ages. So no matter where somebody's at in dealing with mental health concerns, that shouldn't matter. You will have therapists that focus primarily on children, adults, older adults, and I get that. I will say I don't treat children myself, but as far as like young adults all the way to end of life, then I feel like I know my role in those situations. So to talk a little bit about occupational therapy and like why we are involved in that, like I love this quote, which comes from Patch Adams. If you've ever seen that movie or know who that is, Robin Williams played him. He's a physician, but he said, "You treat a disease, you win, you lose. You treat a person, I guarantee you win, no matter what the outcome." And that really hits to the core of that mental health component. And we say mental health, but really it's part of just addressing being a human. It's part of the human experience, grief, loss, fear, anxiety, rage. It's all part of it. And then if we experience trauma or we have a brain injury or something like that, things can really get goofed up. And if somebody can't see us really for who we are beyond all that stuff, then we are only treating that diagnosis. And we want to go beyond that. And that's really where occupational therapists can step in. And the American Psychological Association says that mental health is a state of mind characterized by emotional well-being, good behavioral adjustment, relative freedom from anxiety and disabling symptoms. We don't expect you to be floating around on a pink cloud all the time. That's not the goal. And a capacity, keyword capacity, to establish constructive relationships and cope with the ordinary demands and stresses of life. When I take that very general definition, which I think is pretty good, and I meet my patients and then I lay that over their context, meaning how they move through the world, their challenges, their complaints, their desires, their dreams, their pitfalls, their history, this really helps me find where the therapy is needed. So I have a patient right now who really, really wants to be able to go to college. And she's having a very hard time leaving her apartment, having a hard time feeling motivated, follow through, also has a lot of social anxiety, and has had a lot of difficulties in the past with some issues at school. So when I lay this definition on top of what she's dealing with, helps me start to tease out where she's struggling and then develop a treatment plan around that. So like I was saying, I usually see patients at home, and I think that's a great environment. I also see people at their work, and if that works best for them, I can do that. I also see people telehealth, and I have found telehealth services for people related to mental health is very helpful. Occupational therapy is not meant to replace talk therapy. We do a lot of talking. I'm talking, I'm here all by myself, but we're meant to help people be functional. So with the patient I was talking about earlier, we were talking about doing some things that are much more somatic. So yoga, getting a little bit more embodied, staying present, how to do that, and then practicing that even virtually. Breathing techniques or demonstrations of, dividing your breathing between each nostril, doing it together, trying to regulate that nervous system. So we can do it in a lot of different ways. And I'd say this all the time. I'll continue to say this. Mental health is health. And if that doesn't kind of resonate, this might. So poor mental health also increases risks for long-lasting conditions such as heart disease, stroke, and cancer. So if you're more thinking about like, well, health is your body and all this, your mental health is having a profound influence on the rest of your systems. So, and what an occupational therapist does not do is diagnose. I can do screens and say this person has signs and symptoms of XYZ, but then I have to share that with a physician and see if they're going to take it another step further. So that is not my job. So I can't come in and say, you have this and you have to do this. I can't prescribe medication. I can review things, such as a patient I had recently was telling me she was so tired when she was starting a new medication that she could not get out of bed in the morning. And that I could make the inference that that was related to the new medication. So then I can make a phone call to the physician to help advocate for my patient that this patient seems to be having some side effects of this medication. Once she started, this is what's happened, XYZ, because she was feeling so depressed and so withdrawn. She wasn't calling the physician. So she's on a steady slope down, and I don't want her to get too far down. So we can collaborate with the physicians and other interdisciplinary team members. Some of the things that we do spend time with are neurodevelopmental disorders, schizophrenia, anything on that spectrum, and psychotic disorders, obsessive compulsive and related disorders. There's specialized training that goes into that. Trauma and stressor-related disorders, dissociative disorders, somatic systems, and more. Obviously, depression and anxiety, we see that quite a bit in a lot of our folks. And so we also don't want, just like going back to treating a person, when we talk about mental health, there's oftentimes like a stigma that goes around that. And even our own healthcare providers sometimes exacerbate that stigma in our patients. So then they already come into a treatment thinking, well, what do you think you know about me? Or what are you going to tell me to do? I had a patient that said, every single person I talk to wants me to journal. I hate journaling. So I'm like, okay, check that off the list for this patient right now. So we want to stay very person focused and also take into consideration people's belief systems about mental health and mental illness, their cultural background, and of course, where they live, who's with them, their emotional health. If I have a patient that is in the depths of despair with depression and can't make it through 10 minutes with me without, crying and crying and crying and can't refocus, then we need to figure out how to treat that first so then we can make progress otherwise. So there's a lot of things that we have to do. And we know in the United States of America, 1 in 5 people are diagnosed with a mental illness. 1 in 5. And do you know how many people don't go to the doctor or don't share what's happening? And it's interesting because having dealt with a lot of patients that have dementia, a lot of people can cope with mental health disorders all their life. And it may not even be well coped with, or it might be pretty good. But once we see dementia in the mix, then sometimes those symptoms of the mental illness really start to rear their head. And that's a really good place for an occupational therapist to come in and kind of wade through those weeds to say, okay, what is dementia? What are we dealing with? And help somebody be as functional as possible and do caregiver training. So again, like I told you, occupational therapy is actually rooted in mental health. This goes back to the early 1900s. And I'm proud of that for whatever reason. Some of my most challenging patients have been folks that have had profound trauma, great difficulties with mental health, and to see them grow and become more functional and then increase their self-esteem is incredibly rewarding. So, and then our American Occupational Therapy Association, they also have additional training and resources and stuff. So if you're an OT and happen to be listening to this, there's places to go for support. Some of the things that I work on a lot are creating new routines. And sometimes those routines have to start this small. I was talking to an occupational therapist that had recently come to work at Covell Care and Rehab, and she's coming from an acute care setting. And things move, pretty quick. And we were discussing a new patient. She hadn't seen him yet, and all these diagnoses that he had. And I was giving her some kind of coaching guidance on what to expect, maybe some approaches, assessments to use, things like that. I told her, go extremely slow, watch his pace, because you need to earn his trust, especially, like I said, when somebody's been through the healthcare system quite a bit. There's a lot of jaded folks out there. And she was surprised to hear me say that. And she said, that makes me feel so much better, because I feel like I need to go in there and be like, you need to do this, this, and this. And she said, but reading his diagnoses, I just didn't think I could be successful in that. And I said, I don't think you can. And so we're going to go slow and create positive routines and small successes to build that momentum, knowing that there might be slips down. That's okay. But how to recover. There's actually a model in occupational therapy that has to do with managing chaos, because every single one of us has a lot of chaos. And how do we recover when the chaos gets so chaotic that life is upside down, inside out? How do we recover from that? Well, there's a skill set that goes with that. An occupational therapist can help with that. We look at everything from personal hygiene, medication management. Again, I don't prescribe medications. I can help make sure that my patients are taking medications on time by integrating routines and systems that work for them. Anything from meal planning, money management, social engagements. And a really beautiful part with community-based care is I can go with my patient to certain things if it's appropriate and they want me to. I had a patient who had severe depression, anxiety, PTSD from the Vietnam War, had some really interesting behaviors in social situations, and different triggers really kind of caused him to act in a way that he didn't want to act. So we started going to the coffee shops together. We started going to restaurants together, and not as like friends, but as navigating, like, this is a trigger. This is someplace you could sit where you're going to be able to see everywhere in the coffee shop and your anxiety can come down. Some of those other things that we can do. Some of the interesting things that I've had in the past that you may not directly connect to mental health are, for example, a woman that I worked with that had a stroke was going to be a full-time user of a wheelchair. By the time I saw her, she'd been living at home for a year with her son and would not leave the house other than to go to a doctor's office or through the drive-thru because she was in a wheelchair. She was embarrassed. Lots of shame. She had a lot of pride about being very independent, having a meticulous house, working her buns off all her years before her stroke. And she would become very agitated in town and actually give people the bird. And so we talked about appropriate things. I mean, hey, if you want to give people the bird, that's on you. But also, I didn't want her to feel so embarrassed being in public that she felt like she had to do that. So that's a different thing. I worked with a woman who had a colostomy bag that literally couldn't even look at it. So she was in skilled nursing, and I was doing some PRN work. And the staff called me in to come in and talk to her because I also have a background in pelvic health and all the fun things that come with that. And so I came in to talk with her, and she would rather go to long-term care than home with her husband because she didn't want to deal with that. So we did a lot of imagery and sort of graduated exposure to it, and she did end up going home. We can do things like grief support too, and help people navigate the world after they've been married 50 years and their spouse is gone. So we may not be able to take that grief away, and yet we also can help people be functional, manage their overwhelm, figure out new roles that they're now going to have to take on because they don't have their spouse to take it. So lots of interesting things that we can do. Of course, we're always going to be screening for suicidal and homicidal ideation. If we need to make a call, we are mandatory reporters. And so if we are suspect or hear that there is self-harm or harming others in the mix, we have to make those calls. That's where we do have to break confidentiality at that point to keep people safe, of course. Some of the assessments that I will use just to get a gauge on things and I can take a deeper dive into things. And then I can also use these assessments after I've seen the patient for a few weeks or a couple of months. But I like the generalized anxiety disorder. This is just a 7-item questionnaire, geriatric depression screen, the comprehensive occupational therapy evaluation, patient health questionnaire. So there's a lot of things out there too that can really help us objectify what's going on. In order to bill insurance for specifically mental health, like if I'm not dealing with anything else, I have to have a diagnosis from a physician. And that's usually fine to get. But I also, what happens is just like that woman that has the colostomy bag, the mental health aspect of it and the grief that was coming with her changes in her body were a big piece of why she was not recovering. And that was all directly related to a surgery that she had had because of a colon resection. So, it's all kind of tied together. But if it is just a referral for mental health, we have to have that diagnosis. I'm always going to try to stay very occupation based, meaning that we want to do things that are participatory. Again, I am not a talk therapist. I'm going to talk to people about things, but then we're going to do things together. And that kind of brings on feelings of success as well. The people that we need to lean on as occupational therapists include our patients' physicians. If they have a psychiatrist or a psychologist or a counselor, if they're working with a nurse, they might also be working with PT or speech therapy. I love to bring in the idea of support groups. Sometimes that first group is the hardest one to attend. And I will often ask, would you go if I met you there? And even sometimes I will say, okay, I'll go with you and I'll meet you there. And once you get kind of settled and stuff, I'm not going to stay for the whole thing, but then I'm going to bow out. And I can always talk to the support group leader about my role ahead of time. Religious leaders. So if my patient is connected to any sort of faith, I like to get that part involved as well. And then online support groups are very helpful. I spoke in the last Covell conversation about resiliency groups. And so if you're interested in learning more about that and how you can find those people online, that's a great conversation to listen to. And of course, last but not least, we want to talk about what we can do as practitioners in our own daily routines. For me, I do much better with my patients if I've taken some space in the morning for myself to read some of my scriptures, do some journaling. Unlike my patient, I really like to journal. I read some inspirational type books, business books, books about parenting. I love to learn. Kind of gets my headspace in the right direction, and I can show up clearer for my patients. I also have to have a lot of self-compassion. I may not be my best every single day with my patients, but I'm going to be my best for that day. And hopefully, if it's a rough day, I also can say, I did my best today, and I know that tomorrow I'll probably do a little better or I'll know better. So we have to have that grace with ourselves. And then even our physical health, plan our own healthy meals, hydrate, all the things that we teach our patient. Put a mirror up and think, am I doing all of these things myself? And every single one of us at different times in our lives, probably more than we wish to admit to, can say, no, we're not doing everything the best that we could, but we're always striving for that next best level. And we can help our patients strive and develop that sense of wanting to move forward and feeling successful through occupational therapy for mental health. A few things I recommend if you like to read, which I do, are the books What Happened to You by Oprah Winfrey. And that really can replace things. Instead of saying like, what's wrong with this person, what happened to them helps a lot with a kind of a paradigm shift in your head. Atlas of the Heart by Brene Brown. Who doesn't love Brene? There's a book called Sociopath. It's a memoir. I highly encourage you read it. It really changed my perception of sociopathy, and I think it will change yours too. And then I just encourage anybody. I don't care if you're a neurosurgeon, a CNA, a OT student, a professor, is learn about mental health. Lean into that so that you have a good empathetic barometer, that you have a good radar for other people's needs and individuals. It will make you a better manager. It'll make you a better parent, better friend, better therapist for sure. And that's just a work in progress for all of us, all of our lives. So here's one last quote that I will leave you with. Sick minds, sick bodies, and sick souls may be healed through occupation. And that is where occupational therapy shines. And one of my favorite quotes to really remind us that we are a holistic profession because we are holistic people, not just OTs, every single one of us. So again, thank you for joining Covell Conversations. I hope you'll join me next week. If there's topics that you want to talk about, I'd love to hear. If you'd love to have an interview, if you have skill sets that you'd like to share, especially right now, even talking about mental health, things you've learned, things you wish you knew when you were younger. If you've experienced anything with the mental health crisis and want to give people your insight on what that's like, I would love to talk to you. Anyway, have a wonderful day and see you soon. Thanks for being here.